I can find mentors who can push me further. So I've been fortunate to take courses across the US, Mexico, Colombia, Brazil, Portugal, the UK with Titania,
Yeah,
and South Africa.
amazing.
Uh,
Um, I will leave with you, Dr. Cajee, the way you think it's better to do. You just tell me and we can manage over here.
Wonderful. The If you would like, I could launch straight into the presentation, or if you feel it's
Yeah.
prudent to wait a little longer, I however you feel it's
Mhm.
best, Michelle.
Yeah. Well, I think we can start. We have 5 minutes past. Mm, mm,
Okay.
Yeah, let
Okay.
me see. Yeah, I think it's open for you to share. If you have any problem, just let me know.
Got it. Sounds good. I'll start sharing my screen then.
Yeah.
And I would love to know, where is everyone who's attending the webinar from? Please, please share in the chat box, and as questions arise, we'll answer them after. But I do have some material that I'm excited to share with you all. All right, let's jump straight to it.
Yeah. Yeah, we have Dr. Amar from Egypt, Dr. Raspour from USA, Ethiopia with Dr. Abraham. We have Erica from Dublin.
Wonderful. All right, well, let's get started. So, this topic of soft tissue management for implants is not something we can cover in the depth that it truly deserves in a webinar. It's truly a much more extensive subject than that. However, what I wish to do in our time here today is to give you 5 principles or 5 concepts that I live by as a implant focused dentist. Now, we see these cases more and more. Patients coming back after 10, 20 years. And sometimes after we do cases, we wonder, are these what our cases will look like after 10, 20 years? The truth is, it's a question of what is success. And in some ways, based off our classic definition of success, these cases are indeed successful based off our classic criteria of success, Albrechtsen. Because the truth is, in our classic definition of success, it's whether the implant actually osseointegrated. However, and for many a patient, and I would say a smaller group of patients, having implants in that way are still considered successful. This is an example of a patient of mine, a dear patient. His mouth is actually a museum of implantology. He's been my patient for the last few years. And most recently, he fractured tooth number 7, or as you would say, 1, 2, and requested that I do an implant for him. So he holds my record of being my eldest patient, having an implant placed at 96. And he came out of his hospice treatment in order to have me restore his implant because he did not want to pass without his full set of teeth. Now, for him, having teeth, no matter what the tissues look like, no matter what the cleansability issues are, is considered success. And I think Brennan Mark's dream of patients not having teeth in a glass is fulfilled in a case like this. However, By our standards today, we ask ourselves, is this successful? Now, a very similar case um, crossed my radar most recently, and I finished. In this case, we have a young lady in her 30s, a long life ahead of her. And even though she has a history had a history and treatment for cleft lip and palate, which you can observe on the picture, she indeed fractured the exact same tooth, 712, or tooth number 7. And indeed, I placed an implant for her and restored her to function and aesthetics. Now she's a much different patient than the first one. The first patient, an osseointegrated implant, fulfills his needs. For her, the anxiousness, what will this look like, despite what her other restorations look like? She was so anxious when she looked at this tooth for the first time. And these are becoming more and more of our patients, where they expect nothing less at this time than natural beauty when we finish care. And what does that involve? That involves the proper, not just getting them a tooth that they want, not just focusing on getting them titanium and bone, but how do we manage the tissues appropriately to set the implant system for biomechanical and aesthetic success? Because there's more factors than Albrechtson's criteria to consider today. Peri-implant health, the stability of the prosthesis and function, and aesthetics. So today, what I hope to give you in just an overview are 5 principles I live by. And uh, and what I would hope is with interest, we can dive further deeper because each one of these areas can be a full day course of their own. The first tip is going to be the power of prevention, preserving tissue where we can, and the use of custom healing abutments to prevent even the need for augmentation in our soft tissue management. I will say there's another technique, partial extraction therapies, which also greatly help in prevention, but that won't be the focus of my discussion here today. Custom healing abutments. Now, custom healing abutments present many advantages compared to cover screws and standard healing abutments. Holding tissue contours allow us to minimize the decrease of tissue volume because we know when teeth are removed, not only do we remove a clinical crown, not only do we remove a root that can lead to bone resorption, but we can also lose our tissue volume. And in areas where maintaining tissue profiles are of critical importance, custom healing abutments provide a unique advantage to prevent us from needing any reconstruction in those areas. I urge I urge a review of these 2 papers. I believe these 2 papers have helped me in my understanding of how to shape custom healing abutments and my final restorations. It's the paper by Sue and colleagues and the paper regarding the EBC concepts, which we'll dive into from Gomez, Mehta, and colleagues as well. Now, pre uh, the concepts of proposed by Sue and colleagues, we would often describe our contours of implants as over-contoured, under-contoured. And there really wasn't a definition or a criteria given to what does that exactly mean. So Sue and colleagues, and their concepts are still widely discussed, presented the idea of critical and subcritical contours with relation to the transmucosal portion of implants, of our implant prosthetics. So if you look at the red line, that is the free gingival margin. That's the area we wish to hold. The lines just apical to it are our critical contours. And then this orange zone, the blue line, is our critical contour. And the orange zone is our subcritical contour. And how we manipulate the shapes of these lines, of these areas, can affect our tissue positioning. Now, in posterior areas that may be less critical to some, and I would argue not today. However, in anterior positions, in aesthetic zone cases, how we manipulate these prosthetically are of utmost importance. And this concept has been further elaborated by Gomez, Meta and colleagues in their paper proposing the aesthetic biological contours, the EBC concept, and they've expounded on it. In this concept, we need to look, when we look transmucosal, from the implant platform to the free gingival margins, there's three specific zones we need to pay attention to. There's what we call the C zone, which emerges straight from the implant platform. There's the B zone, and there's the E zone. Now, the crestal bone zone, we specifically need to pay attention to that because that is where connective tissue can attach and form our biological width or seal. From there, we have our B zone, which junctional epithelium can attach. And then we have our E zone, where the margin can be stabilized. And how we shape these areas and the materials we use are absolutely critical. So we can observe here that this is for a platform switch crown. In the three zones, a platform switch crown is often placed subcrestally today. We need the contours that emerge out of the crown to be straight or actually concave. And that's what takes pressure off the bone. We also need that part of the crown or the prosthesis to ideally be polished metal so connective tissue can attach to it. And then in the B zone is where we create space for tissue to fill. Being convex in nature allows the tissue to fill into it. And then in the E zone, the aesthetic zone, where stratified epithelium will be, we then switch from a concave shape to a convex shape, and that allows the stabilization of the margin. Custom healing abutments can be CAD/CAM milled, they can be 3D printed, and they can be fabricated chairside. Each of these in your clinical practice may be of some advantage if you have an in-house lab, milling it if you have a design team on standby, 3D printed healing abutments and milled. You can also design them from the emergence profiles of the natural teeth and have them printed ahead of time. Or as I commonly do, fabricate these custom healing abutments chairside. Here is a case where I skipped, these custom healing abutments can be made out of zirconia, composite, titanium, or you can actually use the natural tooth itself. So here is a case of a young patient in her early 30s who fractured tooth number 9, or I believe we say 2-1. In this case, I sectioned the cervical neck of the tooth, luted that to a temporary cylinder, and used that as the custom healing abutment. No sutures needed and no loss of tissue. If I could do something, being critical of my work, the C zone, the crestal zone, out of this temporary cylinder, I believe put a little too much pressure on the crestal bone during the healing phase. And if I were to redo this case, I would have either smoothened that portion that emerges straight out of the platform, or I would have used an actual tie base or stock healing abutment with a better profile. And then there we are, restored. No loss of soft tissue, tissue profiles preserved, and no need for augmentation. Our second point that we live by, it's the use of tension relieving and compressive sutures when needed. Now, single interrupted sutures are the workhorse of surgery, not just oral surgery, periodontal surgery, and others. But getting into implant perioaesthetics, these plastic surgery procedures, tunneling, and others, we can't jump into these cases just placing single interrupteds anymore. We have to use mattress sutures because mattress sutures help us relieve tension. And they allow us with the right usage to control direction. So two sutures I frequently employ the use of are the modified anchor vertical mattress and the modified horizontal mattress sutures, otherwise known as belt and suspenders. The vertical mattress sutures allow us to, especially vertical mattress, when you think of the blood flow into our flaps, it's often from the base of the flap, the most apical region, coronal. And through the use of vertical mattresses, we can relieve tension and pull these tissues without disrupting the blood flow. And that's absolutely critical as we reposition papilla, or if we tunnel connective tissue under papilla. How do we apply the needed pressure to move the tissue coronally, but relieve it at the same time? And a modified horizontal mattress suture allows us specific control over the free gingival margin and still relieving tension. So we can see here an example of both of these sutures being used. On the left side, you can see the vertical anchored mattress sutures. And on the left side of the upper left quadrant of this patient case, after connective tissue has been tunneled, the use of belt and suspender sutures to specifically control the direction and maintain that of the free gingival margins. Now the use of compressive sutures, especially when harvesting from the palate. Most of our patients, I believe, and treating soft tissue issues, to me, is often like treating peri-implantitis issues. It's very difficult to get sometimes the right patient acceptance. The reason is because patients want teeth. They don't want implants. And now you tell them they have to have their tooth extracted, they have to have their tooth bone grafted. They don't want a bone graft. And now on top of that, in order to get them to ideal, we now tell them you need gum grafting. And they're thinking to themselves about their neighbor who told them 10 years ago it was the most painful process in the world. So it's important in these cases to break those misconceptions because our techniques have evolved. So the use of compressive suturing over palatal harvest sites, and specifically using the one incision technique, which we'll describe later, dramatically help with patient comfort and wound stability and allow them to heal faster. So something you can observe here, when I do my palatal harvest, I'm often just doing one continuous suture. This is a compressive suture, which we nicknamed the X box. And you may observe looking at the buccal shot, I only have one knot. And the reason for that is patient comfort. The more knots we have in this area on the vestibule, that's what annoys patients the most. You may also further observe how long the tails of the suture are. When using monofilaments like polypropylene or nylon if you choose, keeping long tails allows these sutures to lay down flat, and that aids in patient comfort. So I urge the use of tension relieving mattresses, and I urge the use of these compression sutures when we deal with soft tissue management. Patience. Understanding when and why a staged approach can lead to more predictable long-term results. Now, we live in a world where we want everything fast, quick, um, free, and painless. And the truth is, for many of these cases, unfortunately, we're in a position where we can deliver neither of those. Some cases, they can't be fast. Some cases, they're not cheap. And some cases, sorry, they're not going to be painless. And how we set up our patients' expectations for these types of cases are extremely important. One of my dear colleagues and friends said something to me some time ago, and I wish to quote him today. He said, always stage unless there's something worth preserving. And it's taken me time to understand and realize what he meant by this. Now, in the case of immediate implants in the aesthetic zone, where those soft tissue contours are worth preserving, whatever we can to preserve those, we do. However, in other cases, often a stage approach can buy us more options at each stage of the procedure. And let's dive into a case. Here is a case where a patient presented with a tooth previously extracted, a graft done at a previous at another office, with a prosthesis, temporary prosthesis that's putting considerable amount of tissue on their dentition, on their periodontal tissues, and wants to be restored to health. Now, if we take the time to say, what type of complications can happen from jumping in such a case? What are we even dealing with here? Can we place an implant, a healing abutment, a temporary crown, all in one visit? Are these the tissue profiles we wish to preserve? Or do we need to do more? What's waiting for us in a case like this? What do we not know? She's been grafted. The CBCT shows there's bone, but what is there really? And then we dive into a case, and the bone that was grafted is mush. Some may ask, the incision here, wow, that's quite a wide incision to do a wide envelope flap. However, in many of these cases, we can only understand what we can see. And even though a CBCT may show some volume, we have to open up some of these cases wide enough to see what we don't know. And we see a significant defect. So how do we proceed? Do we place our implant? Do we place a connective tissue graft at the same time? Do we GBR it at the same time? What risk are we willing to undertake? Now, I know some who would say, starting off this case, if the CBCT showed significant volume, let's go with the papilla-sparing incision. Let's open up conservatively. But if we jump into this case with a papilla-sparing incision and we see a significant defect, What options does that leave us to graft? If we open up further, now, in this case, the decision was made to place an implant with a simultaneous GBR and close. And we're able to do so because we had a wider incision opening. So the the top pictures, the pictures above, are pictures of this case after the GBR and implant placement. And the bottom are pictures of a similar case sent to one of my dear colleagues to ask for complication management. And in some ways, these cases are two sides of the same coin. In the in the case below, the clinician chose to place their implant, chose to go in with a much smaller incision, and chose to place a healing abutment at the same time. And you ask yourself, by trying to do this quicker and more conservatively, are we prepared to handle the complications that ensue? Or is it better to play it more conservative? What is worth preserving is the larger question. After the implant was placed, in this case, it's been buried, but a technique I like to employ is at the time of the placement, that's when we take our intraoral scan body impression or physical impression, but that's when we impress the implant, is before closing in a stage 2 case. And what that allows us to do is now we have the option to either move to a custom healing abutment at stage 2 or move to a provisional restoration or even move to a final crown at stage 2. And we need to decide for ourselves what risks are we willing to accept in these cases. So after the implant was placed, the lab did a mock-up. And from there, it's important to work with our laboratories. They only know what we give them. It's important for the clinician to be in the driver's seat because we own the cases in the end. If we have a crown that's over contoured, under contoured, it's not the lab's fault. It's you, it's the onus is on you, the clinician, to instruct the lab to your exact needs. So in this case, after the mock-up from the lab was sent over, the lab was then instructed in the B zone to further contour the crown for more concavity, to allow more tissue fill. And then to make the E zone more concave to stabilize the gingival margin. Now, in this case, if you know your materials well and you can trust your materials, trust your lab, you can choose then to move things along quicker. And here's the case at seating. No healing abutment was done here. The patient was taken straight to the final restoration. A zirconia custom abutment was fabricated of highly polished zirconia to allow for tissue adhesion, and the patient was restored. Now, this patient was also instructed on other needs and other, whenever you consult a patient, you have to look at the broader smile. Would they benefit from crown lengthening? Would they benefit from restorations on their neighboring teeth? And to dial a treatment into their needs. And this patient purely wanted her front teeth dialed in, and we believe we achieved the results we needed for her. You can just see it in her eyes. Now, would I want more out of a case like this? Being who I am, yes. I would actually prefer scalloping the tissue across, evening out all the gingival profiles, restoring her to what I would believe more a complete state. But it's not up to me. It's up to the patient and the patient's wants and desires and their ability to commit to treatment. Now, this is a I these points were given to me from a colleague, and there's a lot to unpack here. So I urge screenshotting this slide and potentially reviewing later. But it's important to understand the benefits and trade-offs of when we go single stage and when we go two stages, because there's advantages and disadvantages to both. You know, the advantages to single stage implants, number one, are less times you have to anesthetize your patient, fewer appointments. But you have to decide whether that is the best treatment for the patient. The two-stage approaches, I believe, have significant advantages. One is undisturbed healing. The second, to me, is the opportunity for localized soft tissue augmentation when we're embarking on these cases. Now, in what I mean by localized soft tissue augmentation is when we're going single stage, we often have to harvest tissue from another area of the mouth, the palate, the tuberosity. However, in two-stage techniques, we can often locally harvest and use our buccal roll flaps and other techniques. The the other advantage to two-stage is we can get more predictable, I believe, hard tissue augmentation, and then use that as a stage to get to our soft tissue augmentation. I'm going to show you another case of mine. This is a patient who presented to me with a severe buccal space infection, teeth infected, broken through the cortical boundary of the inferior alveolar nerve, presented in significant pain and swelling. Now, in a case like this, how do we stage her? Do we remove these implants and place immediates? Too risky for some. Some may say, let's do it. The um, At what stage do we jump in? Do we wait for healing? How many procedures do we put her through? I'll show you what I did, and then it's up to clinicians to decide how they would manage the case. In this patient's case, I wanted to purely focus initially on removing the infected teeth and managing her resulting paresthesia. Once her paresthesia resolved, I went back in and I performed a GBR because curating these areas and the amount of bone destruction was significant. From there, once we established that we had sufficient bone volume, prosthetically driven case, we first want to see where we need teeth to be. Do we have the appropriate bone support? And do we have the right depth to get the right tissue profiles? Re-enter. The bone looks nice and healthy. Place our implants to our desired depth based off our prosthetic planning, and I closed. Some may say, why close? The truth is, even though I'm feeling cortical bone, even though I grafted this with significant amounts of autogenous bone, I don't trust it until it's integrated. I just don't. In areas where there has been significant infections due to root canals, due to other things, I believe those are always the cases where if there's some residual element of infection, this case is doomed from the start. And I don't want to risk that in a patient who's already been through so much. So I closed. Came back later, opened, and I placed a stock abutment and a custom healing abutment. Some may say place stock abutments. You can. Now, I just wanted a little bit more out of the tissue profiles, a little bit more tissue support. And then restored. We brought her back to function. We brought her back to restorative health. She has more than significant volume of soft tissue support around these implants. And now she's at periodontal health in this area. This patient is dear to me for many reasons. One is what it took to get her through, how much she went through being infected, and restoring her to health. And then, halfway through our journey together, she messaged me and she said, with all the craziness that happened to her dealing with this issue, she's been inspired to become an RDA, which we call a registered dental assistant, or in the UK, you refer to as dental nurses. And I hired her, and she's one of our team members. And I believe that's the power of implant dentistry today. Less is more. I live by this. I would say one of my largest objections to our soft tissue augmentations with connective tissue grafts has been how painful harvest sites can be. And we touched on this earlier. Now, I believe there is always an augmentation, there's indications for free gingival grafts. If you need significant bands of keratinized tissue, connective tissue grafts can give you attachment, but they can't give you that band of keratinized tissue. However, I see myself needing the use of free gingival grafts less and less because of how effective connective tissue grafts can be. And specifically harvesting connective tissue grafts for patients, I like to make as painless as possible and set the patient up for future success. So the idea of the single incision technique was first put forward by Hertzler back in 1999 and further developed by Lorenzana and Pat Allen and other colleagues since. Now, when this was truly a novel technique when it came out, and I brought a sampling of cartoons and illustrations from the literature to further elaborate on this. But in order to harvest the connective tissue we need, I often use tuberosity, but specifically from the palate is where I get my largest grafts from. We enter the palate with a single incision, a horizontal incision first, and then at the axis of the teeth, we make a split thickness dissection and we harvest that deepest layer of tissue. When we do this, it gives us a epithelial cover of our harvest site. And because of that, patients heal so much faster than having a gaping open wound in their mouth. Here's an example of one of my harvests, where we can gently tease out the connective tissue from the palate. And often, I'm surprised how much tissue we can harvest, nice and conservatively for our patient. I also like to employ the use of the palatal augmentation technique, where after I harvest, I place bovine collagen in my harvest site. And what that allows me to do is augment the palatal tissues while I'm at it. I don't want to lose tissue volume in the palate. When the technique was first developed, they closed with no hemostatic agents, no augmentation materials. But I believe if we're there, why don't we aid in the patient comfort? And why don't we augment the palate at the same time? And you can observe the thickness that we can get of the palate. Compressive sutures, patients that are comfortable. And I'm pleasantly surprised when my patients come back and they tell me, and I ask them, okay, what hurts more? The area where we put the graft in or the area we took where we worked on, or the area where we took the tissue out? And most of the time they tell me the roof of the mouth did not hurt much. What I tend to do is I augment the palate with bovine collagen. I use compressive sutures, and then I use just a little bit of periacryl tissue glue over the incision, and my patients go home, no bleeding, and minimal discomfort. Here is a case example of one that where I harvested, and I was actually personally a little scared. The I thought I left the epithelial layer, the outer epithelial layer, too thin, and I would get significant necrosis and have that lead to significant pain and scarring. So I sutured it closed, as I normally do. And as the patient returned, a few weeks later, you can see how well the palate healed. And I believe that this attention, not just to our donors, not just to our donor sites, and where we're looking to augment papilla, where we're looking to augment buccal tissues, move free gingival margins, but our attention to our harvest sites speaks volume. So, what are the key advantages? We've discussed them significantly. It's for me, it's the reduced post-op morbidity of our patients, making sure that they can heal as quick as possible, making sure they're comfortable, making sure that the aesthetics of the donor site are pleasing, because you can do a beautiful job and they look at the area where you took tissue from, and if they see gnarly scars, that taking a long time to heal, that'll change their opinion of the procedure and be less willing to undergo more soft tissue augmentation. And there are times when, no matter our best efforts, we're not dealing with hard tissue, we're not dealing with restorations that once you put them, they're set. We're dealing with tissues where we're leaving it up to the body's mechanisms of healing, where sometimes we have to augment numerous times. And I want my patients the most amenable they can be to future augmentations. Here's another technique used, and on the next slides, of a buccal roll technique, another minimally invasive technique. Of course, we start with our prosthetically driven cases. And through the use of our digital tools today, specifically knowing where we can guide our implants allows us the precision to avoid hard tissue augmentations like sinus grafts at times, and more precise placement. So whether you're a novice trying to get guidance with your angles, or someone more experienced just looking to speed up your case and um, achieve higher precision, digital planning is something we do in all of our cases today. And it allows us to be more precise with our tissue management, because now it's very rarely, I would say extremely rare, that I tissue punch if I'm guided. I don't tissue punch. Why lose some of the best tissue you have for just why lose it? Why punch out your prime keratinized tissue? Instead, when I'm using a guided approach, I pull tissues right from the most palatal aspects all the way to the buccal. And then I use a buccal sling suture or modification of it to stabilize my tissues and gain extra tissue thickness, because that is what's going to stabilize my peri-implant tissues long term and lead me and my patients to the greatest success. So here's an example of how I suture my buccal roll flaps. It's similar to the vertical anchorage suture. I use an external vertical mattress. I first gather this vertical mattress, an insertion point on the mesial. I sling it around the healing abutment, another vertical mattress on the distal, and then we bring our tissues, in some ways, I could argue, in a relatively compressive nature, around the healing abutment, and you'll be amazed at how beautiful it hugs around the healing abutment. Instead of these tissues moving coronally and covering the healing abutments, how well they tuck in around the healing abutments, and the stability it brings to the tissues, and the thickness it provides. Such a simple technique, such relatively simple suturing technique that leads to great results. And foundation.
Dr. Cajee, sorry.
Yes,
Before you continue, we have question or comment here in
yes,
our chat. Maybe you want to check now because it's related to this last.
sure. Thank you for the question, Surcheta. Doc, one of my cases in the palatal flap receded, exposing the bone beneath and caused significant discomfort. So, of course, it depends on how much tissue is taken from the palatal aspect, right? If you take too much tissue, now you may end up with a tissue defect, right? So it's a balance of how much tissue is taken. Um, the one of the palatal flap exposing the bone beneath. Now, something that can be done in these cases is you're left with, I would say, two choices with this patient with the significant bone causing discomfort. One is if you observe this on follow-up, I often gently just re-stimulate that area of the exposed bone and caused just bleeding infill and tell the patient to treat it like the wound is fresh and give them post-operative instructions and see if that can fill. Now, that's if it's mild. If it's significant tissue defect, now you may be looking at needing to augment those tissues. And I would often do that with a connective tissue graft. I hope that answers your question. Now, my last point will be the 3D positioning of implants. And to me, there's all the angles of implant position are important, but I'm going to argue there's one you cannot recover from. So before I do so, all of our implants, I believe, need to be prosthetically driven. We're in 2025, right? We don't place implants without the restorative plan in place. Now, for myself and other colleagues, I love to plan these cases digitally. We always begin with where the free gingival margin needs to be, where the bone is, where the tissues are, and we plan our implant placements. The criteria of how much bone volume we need in the various aspects around the implant, the literature has established very well. And there are ways to bend some of these rules or these ideas with certain types of implants if you understand them. However, I would still say 1.5 millimeters between implants, between teeth and implants, 3 millimeters between implants, and at least 1.8 or 2 millimeters to the buccal. That guarantees you success. Now, we do have in our time a tendency for palatal bias, and that is something that helps us in many cases. However, I'm going to argue the one area that is a make and break of our implant cases is our coronal apical depth. That is the one part of an implant case, if done incorrectly, you cannot recover from. You can recover from angulation issues to a degree, either prosthetically or through augmentations, but you cannot recover from the incorrect implant placement depth. And I'm not talking about if an implant is placed too deep, because I believe you can actually recover from that. But if an implant is placed too shallow, I believe you're toast because you've now forced the patient prosthetically into a ridge lap. And something I've come to learn, this is a patient who presented to my care from a dear colleague. The patient wanted to improve their tissues on tooth number 6, as I believe referred to in the UK as 1-3. And the patient was young, in her early 30s, I believe. Implant was placed by a family friend. She did not want to return to her family friend, and she wanted a solution for this. And this was the case that I learned this lesson I presented to her two options. I can augment the tissues. I can't correct the implant position. We're at a disadvantage here. I can augment the tissues, or we can remove the implant. We can reestablish the bone. We can augment the soft tissues on the neighboring teeth. Then we can place a new implant. Then we can do a new restoration. And that's what it would really take to fix your case. Or, as I said, or I can augment the tissues. What do patients want? Patients want the easiest fix. And for her, even though everything was explained in detail, right? All she heard is, I can fix it with one thing cheaply, or I can fix it with a lot of things more expensive. And in this case, this is where we started. You can observe here the implant platform is almost 3 millimeters coronal to where the free gingival margin should be. And we have recession on neighboring teeth. So the implant was placed here when ideally, or not ideally, the implant actually should have been placed apical to that free gingival margin, 3 to 4 millimeters. Now, did we help the patient? Look, we gained keratinized tissue. We gained it. The restorative doctor, a dear friend, worked her very best to make the best restoration she possibly could. Was the patient happy? No. The patient was distraught, right? Did we present all of our options to her? Yes, we did. Did we do everything possible for her? Yes, we did. But it's just a matter of understandings. And that's when I learned the lesson that in cases where the implant is too coronal, the platform is too coronal, the case is a non-starter. I do not proceed with any augmentation. The plan is explant, augment, replant, and whatever we need to do. And this is being further compounded today because the understanding of where to place implants in a 3D positioning is something that has to be clarified and taught. And we're also dealing in a time where a lot of implant training is done by an implant systems approach versus a principles approach. So many different types of implants on the market today, so many different types of platforms, so many different types of titanium. However, each of these platforms present opportunities and challenges. Each of these types of connections, whether they're uh, conical connections, internal hex, whether they have polished collars, whether they're tissue supported, this further compounds this confusion of where we need our implants placed and how well they perform. So I ask, is all titanium the same? The truth is, whether you were dealing with grade 4, grade 23, the truth is they all osseointegrate. By Albrechtson's criteria as we started today, they're all correct. They will all integrate. But where we put them, how we manage the tissue around them, what they allow us to do is the larger question. And that requires a whole discussion of its own, an understanding of how we know what implants to use, how well they perform, or how they can perform, is a question for another time. So with that, I want to drill home a few points. One is our implant position is determined by our proposed mucogingival margin. That's what determines it. So when we're doing a immediate case, when we're doing a delayed case, it's the same thing. Before we ran off the CEJ of the neighboring teeth, which to a degree is correct. But I would say we're not placing implants in the neighboring teeth. We're placing implants in our site. And even though my talk today focused mainly on single cases, The truth is, this applies to multiple cases. This applies now to full arch cases and tissue thickness. We have to have significant tissue thickness. When we lose implants, when we lose teeth, we don't only lose teeth, as I said before. We don't only lose bone, we lose our tissue thickness. And how we augment our tissues, whether it's preserving the tissues if they have adequate tissue thickness to begin with, whether it's using buccal roll flaps, whether it's tunneling connective tissue, tissue thickness needs to be adequate. Because as we know, bone sets the tone, tissue is the issue. And as I most recently heard, thick is fit. That's what sets us up for success. So, with that, I'd like to thank you all for spending your time with me, your precious time, and having the opportunity to speak with you all. And once again, thank you, Michelle. Thank you, Rada, Titania, and for this. I'll now open us up for questions.
Well, excellent presentation. Thank you very much for so much, so good content. And yes, so people feel free to ask or to bring some doubts you have.
Or let me ask questions. What challenges are you experiencing with soft tissue management? And let's learn together. Thank you, Omar. Truly appreciate your feedback. Luke, what are your tips for soft tissue management in immediate implants? Great question, my friend. The soft tissue management for immediate implants. Let's see here. I did something to my screen. Um, okay, soft tissue management for immediate implants. The goal is often, if we're in the aesthetic zone, to preserve the tissues and augment immediately. The with the caveat, where is the free gingival margin? Is the free gingival margin in the adequate place? Now, I would say, is the free gingival margin coronal, immediate implant, custom healing abutment, or temporary crown? If the free gingival margin is apical to where I want it to be, it's a delayed case. And we're often looking then as we need bone, we need soft tissue to get there, and we need our prosthetic design. I hope that answers your question, Luke. Or let me know if you need further clarification. Sucheta, thank you. For me, I've always found free gingival and connective tissue grafts unpredictable. Sometimes it delivers results, sometimes it doesn't. How could I deal with these inconsistencies? Great question. Because what we're dealing here, and it's a very frustrating for us as dentists, is that we're used to the predictability of dealing with hard tissue like restorations. We're not used to dealing with the unpredictable nature of soft tissue because so much has to do with the patient's ability to heal. And that's where harvesting the right amount of connective tissue, having it placed in the right place with the right amount of stability and blood flow, the right patient instructions, that all comes into place. And then opening up the patient and a conversation, letting them know this may not be your last augmentation. We may need more. You need to have that conversation with patients. and then staging the cases. Great question. I love your questions, Sucheta. The question is, one more question. What, according to you, is the right time to augment soft tissue? Prior to implant placement, during, or after? The truth is, there's never a right and wrong time. Prior to implant placement, if, especially if you're looking at needing GBR cases, try to bring together tissues that are thin, friable, and you need to add bone. You're setting yourself up for a difficult time. So the so ultimately, it's going to be what gets you the most predictability. If you could augment tissues ahead of time, get the tissues to where you need to be, now after you place your implant, you may feel the most comfortable doing a one-stage approach. Now, if you place your implant and you see the tissues are thin, then I would say, you know what? Let's augment tissues and do a two-stage approach. Or don't augment tissues and do a two-stage approach and do a buccal roll flap. There's so many ways that we can intervene and we can enhance our cases with soft tissue. Or you may say, do it before, do it at second stage, and do it before the final restoration. It just depends on how much tissue we need to get in these cases, how well the patient heals. There is no hard and right answer here. From next question, regarding zones E and B, aesthetic and bounded, could make it from titanium, or do you prefer polished zirconia? You could make it from anything. So many different materials. But as we know, every material has advantages and disadvantages. So in the B zone, we have come to learn that there is a unique advantage of highly polished zirconia, that we can actually get junctional epithelium attachment to highly polished zirconia. And that is a unique advantage of highly polished zirconia. Now, if you have enough of the B zone, enough, you've placed your implant at a good depth, you have at least 3 millimeters in that space. Will titanium work? Yes, it will. But there are sometimes unique advantages of other materials. And then in the E zone, the aesthetic zone, I would say it's the same. The material selection isn't as important. I could stand to be corrected. More so the shape and transition from that concavity to that convexity is more important. The shape is more important than the material. I have my contact info here. I always appreciate the opportunity to connect with colleagues and be part of each other's journey. So you can find me on Instagram, WhatsApp, my email. If you're, the truth is, um, we're all students. No one has all the answers. Just like no books have all the library. Just no library has all the books. No person has all the answers. So, if there's any way that I can continue to be part of your journey, um, beyond our webinar today, feel free to share my information. I know Titania does an amazing job bringing resources to all the doctors that they are part of, and I personally have benefited much from them. Um, let's see here. In the anterior zone, which custom abutment do you prefer? Pink iodized custom healing abutment, custom zirconia, gold anodized custom healing abutment? I love this question. Great question, my friend. Now, the truth is they all work. They all work. Um, all of the, you're asking me at this time, my friend Omar, to choose between three great dishes at a buffet, right? You didn't give me a bad dish. You gave me three good options. Now, between, pink, a pink iodized custom abutment and a gold customized abutment, they're the same in my book. Because and I know you are an amazing, um, you run an amazing lab service. Uh, if the surgeon has set up the case right, it doesn't matter in this case because you should have enough tissue thickness to block out any color of the abutment. We know we need at least 2 millimeters of tissue thickness. And the ideal is to shoot for 3 millimeters of tissue thickness. So in that case, the coloring of the abutment shouldn't matter as much. Now, I will say there is a unique advantage, and I use gold anodized, right? There is a unique advantage over polished zirconia. Um, however, from a lab perspective, there may be an increased cost of first you need a tie base, then you need a custom zirconia abutment on the tie base, and then potentially an Emax crown on the zirconia abutment. So the economics of the cases change once we move to these solutions. And uh, so my preferences in these cases are actually, I would feel comfortable if the case is set up with any of these because you gave me three great dishes.
So excellent, Dr. Nabil. Thank you very much. It was a great, great, great pleasure to have this time learning from you. And yeah, as you said very well, so it's very nice to be connected. So, guys, if you have any questions, anything you have in the screen or the contacts of Dr. Nabil, also we have our contact at Titanium as well. So, yes, keep in touch. Dr. Nabil, great, great pleasure. It's an honor to have this time with you. Hopefully, it will be just the first of a lot of other opportunities.
I
Yes,
hope so, my dear friend.
excellent. So, guys, thank you very much, everyone. Have a great, great, great night. So, yeah, let's keep in touch. Bye bye.
Take care, everyone. Thank you for your time today.
Thank you, Dr. Nabeel. Thank you.